Dr. Mayur Brahmania has recently moved here from Ontario. So welcome to Alberta. And he's going to present today on how to prevent and diagnose and treat liver cancer. He is currently an associate clinical professor at the University of Calgary in the Division of Gastroenterology and Transplant Medicine. Mayur's been involved with the Choosing Wisely Canada campaign as the Canadian Association for the Study of Liver Quality lead, and who led the development of the top 5 list recommendations for hepatology, and his group is currently working to develop strategies to benchmark quality indicators for chronic liver disease and liver cancer across Canada. He also works with CWC, Choosing Wisely Canada, on the Diving into Overuse in Hospitals campaign to promote choosing wisely principles in Canadian hospitals. In 2021, he was awarded the Young Scholar in Quality Award from the Canadian Association of Gastroenterology. Take it away.
Thank you, everyone. Actually, start back to the beginning. So what is the liver? So many of you already know that it is actually the largest organ in the body. It's the only organ in the body that has a dual blood supply. So as you can see from the graph there, you get blood flow from the heart, from the bowel, and then eventually all the blood goes to the liver, and then you have some veins that take it back to the heart to enter the circulation. Many of you might have known that it actually performs over 500 unique functions in the body. And I think many of us know, or we hear anecdotally, that it's one of the only organs, well, the only organ that actually can regenerate. So what are the major functions of the liver? So the first one is detoxification. It generally metabolizes toxins, and so you'll hear about in the media about how this is a liver toxin or liver detoxifier. Those are usually a myth, because if your liver is working well, it actually can perform that on itself, so you don't need any enhancements. The liver actually filtrates blood and regulates circulation throughout your body. It's a manufacturer or production that are used throughout the body. It can help produce proteins, lipids, and the sort. It's a storage organ. It makes bile that helps digest food, and you heard Simon talk about this earlier, where you can have dysfunctions that alter your bile flow. And then it actually helps regulate your temperature as well. Many of you may have heard that once you have cirrhosis, that you often feel cold. And so, as Mark alluded to earlier in the talk, we all are born with, hopefully are born with a normal liver where there's no fibrosis. We often term fibrosis as scarring over the liver. And as a result of insult and inflammation, which may be due to viral hepatitis, MASL, as you heard the new terminology, alcohol, or other autoimmune diseases that I've listed here below, over many, many years, this inflammation leads to scarring of the liver, and then what we call cirrhosis, or end-stage fibrosis, or stage 4 liver disease. Those are all synonymous terms that you'll hear other people talk about or in the media. And so what's happening at a microscopic level, here you can see that there's a normal hepatic sinusoid. And so you can see that we have nice cells that are healthy, they're evenly spaced apart, and so forth. And as we start seeing injury to the liver, you're going to have an activation in the stellate cell, and you can see how it starts to proliferate and start looking ugly. And again, this could be due to hepatitis C, non-alcoholic fatty liver disease, alcohol, and liver disease. And eventually, you can get extensive scarring of the liver, which can lead to changes in the liver function, liver failure, or even liver cancer. And so when you look at the natural history of chronic liver disease, you can see that from a chronic liver disease state, over many years, usually about 15 to 20, you move to a compensated cirrhosis state of liver disease. And then there's a 5% chance per year where you'll develop decompensated cirrhosis and the complications. And ultimately, this can lead to death. And why is it important to distinguish compensated from decompensated? Well, not only will it tell us the complications that you'll have from liver disease, which would include variceal hemorrhage, ascites, or hepatic encephalopathy, you're also more prone to develop hepatorenal syndrome, which is kidney failure associated with liver disease, and liver cancer. And along with this, we are able to tell, on average, how long patients may be able to live. So if you're on the left side of the graph, where you see the compensated cirrhosis, the median life expectancy is about 10 to 12 years. Whereas if you move to the decompensated state, your average life expectancy is anywhere between 2 and 3 years, if you do not find a therapy for the type of liver disease that you may have. And so what are some treatments that are available? Well, of course, alcohol abstinence, if that's a major etiology of your liver disease. Treatment of hepatitis C or treatment of hepatitis B, which are again treatable and or controllable. And then steroids for autoimmune hepatitis. So when you look at a liver, the blood flow easily flows through the portal vein, which I outlined over there in the red. It's healthy and it functions well. When you have cirrhosis, blood flow is not flowing through this vein, and you see increased pressures on the portal vein, which then leads to the development or the definition of portal hypertension, and really is the hallmark of cirrhosis. When you move to decompensated cirrhosis, as I mentioned previously, it's defined by the following. So number one, ascites or fluid in the abdomen, hepatic encephalopathy, where patients may experience confusion or disorientation, sleepiness or forgetfulness, and then variceal hemorrhage, where you can have vomiting of blood due to systemic collateral formation of the esophagus. And lastly, you can develop hepatocellular carcinoma, which is the most common risk factor is cirrhosis itself and the focus of the talk. And so who's at risk for developing hepatocellular carcinoma? Well, generally, you need to have underlying liver disease. If you're older age, if you're a male, sex, diabetes, you have advanced liver disease, hepatitis B or C, and if you have a family history of liver cancer. It typically occurs between 1 to 5% of patients per year. And so this leads to the important point that liver cancer is curable if detected early. And so many of the patients that we see with liver cancer are asymptomatic. And the only way to truly detect liver cancer is through a combination of an ultrasound of the abdomen along with a blood test that we do called alpha-fetoprotein. Typically, we like to do this every 6 months to a year in patients that have cirrhosis or those with hepatitis B infection without cirrhosis. Generally, if there is an abnormality that's detected on your ultrasound, we will follow that up with another imaging modality, which may be a contrast enhanced ultrasound, a CT scan, or an MRI. And this has diagnostic features of liver cancer. And so many patients ask, do we need a liver biopsy to diagnose cancer? And usually not. And so this is because A lot of the imaging modalities that we have, such as MRI or CT, are good enough. We have diagnostic criteria that we use to make the diagnosis. However, this is not always the case, and you may require a biopsy because sometimes the MRI or CT, we don't get good visualization due to patient factors, or sometimes the scanner wasn't perfect that day, and so there's sometimes, very rarely, but there is sometimes that we will pursue a liver biopsy. And so a lot of people wonder, what are the staging systems of liver cancer? And so when you look at other types of cancer, most liver cancer is located within the liver. And how we stage your cancer will depend on the size of the tumor that you have, the number of tumors that you have, and the location of the tumors you have. We also will determine if the liver cancer has extended into the major blood vessels in and out of the liver, or is it solely within the liver? Then we'll assess if your liver is compensated or decompensated, and if you have any other medical comorbidities. Ultimately, what happens is that we discuss a case of liver cancer every week with a dedicated team of professionals that are experts in liver cancer, and this includes hepatologists, diagnostic and interventional radiologists, hepatobiliary and transplant surgeons, medical oncologists, radiation oncologists, and some tumor groups also have pathologists that will attend these rounds. Multidisciplinary tumor board rounds have been found to reduce the need for excessive consultations, enable timely care, and reduce redundancy in care. And so every case should be ideally taught at multidisciplinary rounds. And in Calgary, we have a robust program where we discuss at least 12 to 20 tumors per week. Ultimately, what we use is something called the Barcelona Cancer Staging System, so BCLC. And really, it's a complicated Plinko algorithm that I don't expect that many of us would read, but typically we try to fit people into 3 categories. So early stage cancer, which is on the left side. In the middle, we have something called intermediate cancer staging. And on the right side, we call it advanced staging system. So depending on where you fit on the risk factors that I talked about previously, we will try to identify patients into a cure or not curable. So if you fit into the curable category, there's many types of procedures that you could have. And one of the most common and frequent is called radiofrequency ablation, or similarly, there's another technique called microwave ablation. It is usually a day procedure, and what you're doing is taking a catheter probe, which they'll insert through your groin and locate your tumor under CT guidance, and they'll burn this tumor. And as a result, you may have side effects of back pain or fever, and less likely recurrence of your cancer, depending on the size. Usually what we'll do is get an MRI or a CT scan in 3 months to confirm that the tumor has been treated and hopefully cured. Another type of therapy that we have an option for includes resection or surgery. And that will depend on if your liver is healthy enough and if the patient themselves are healthy enough to withstand surgery. Surgery can remove a small portion of the tumor if it's located in a particular segment, or we can remove the entire lobe. And this is where the concept of regeneration that I talked about happens. And typically, a patient's liver will grow back in about 6 to 8 weeks after that's done. A lot of these resections are done laparoscopically nowadays due to advancement in technology, but also open, where they'll need to make a midline incision through your abdomen to get to your liver and take out the piece of tumor that's located there. Usually you're in hospital for about 3 to 5 days. Obviously after a resection or surgery, you may develop blood clots, infections, wound complications, worsening of your liver disease, and then there's also a chance of recurring cancer. Another more plausible treatment type is liver transplantation. And this is where the entire liver is removed and is replaced with a healthy donated liver. A liver transplant is considered when there's no metastatic disease, and so that means disease that's outside the liver, whether that be in your lungs or your bones, or the most common frequent sites, and can't be treated by other less invasive forms of curative treatment that I mentioned. We have size criteria, and there are numerous other criteria that we use to determine if a candidate's liver transplantation. And in general, this is a type of therapy that's offered in about, almost every province across Canada, and 6 to 8, in total we have 8 transplant centers in Canada. And you can see that each province has different criteria for if you're a candidate for liver transplantation. And this is one of the things that I'm working on, is how we can standardize criteria across Alberta and Canada to ensure that there's equality in terms of who would be able to get a liver transplantation in the setting of liver cancer. Because ideally it's the same wherever you go, and it's one of the core tenets of our universal healthcare. When we move to non-curable types of therapy, one of the first type of therapies you'll hear about is called embolization. This is done by interventional radiologists. There's 2 types of embolization. So the first is transarterial chemoembolization. It's often called TACE. And so this involves delivering localized chemotherapy to the tumor site. The other is called transarterial radioembolization. Another name for that is TARE or Y90, and it has the same concept, but I like to think of it as a bazooka to your tumor, and really it's really a new form of therapy that's really well tolerated, and we see excellent outcomes with that, and this procedure is also performed in Calgary. Typically, you're in a hospital just overnight, so patients come on a Sunday, they have the procedure done on a Monday, and usually they're back home on a Tuesday. You may develop liver failure, chemotherapy side effects, and usually a CT or MRI again is done in 1 to 3 months. We also can offer radiation therapy, and this is done by a radiation oncologist. We give radiation over 5 courses every other day. And this is also known as SBRT, or stereotactic body radiation therapy. You may get skin sensitivity, nausea, or fatigue. And similar to what we do for all tumors, we want to ensure that you have some form of imaging within 1 to 3 months to ensure that there's no cancer recurrence. So where does chemotherapy and fit in? And so this is typically, when you hear the word cancer, you think about either surgery or chemotherapy, and then outline why we have so much more in our therapeutic arsenal that I listed before, but we still have chemotherapy in our back pocket. And recently, in the past 3 years, there's been remarkable changes in the way that we give chemotherapy and how effective chemotherapy are. When you looked at the first type of chemotherapy that came out for liver cancer, which was way back in 2008, there was a period of stagnancy where we didn't have any new chemotherapeutic regimens until about 2017, 2018, where we had an explosion of trials that were positive for liver cancer. And so one of the first trials that came out just a couple of years ago was this drug called atezolizumab and bevacizumab, which can be used as frontline therapy. Another trial was published last year with this drug called durvalumab and tremelimumab, which again is first-line therapy. These are available in Calgary and Alberta. We often have patients that don't tolerate systemic chemotherapy. So there's also an option of oral once-a-day pills, which are labeled as lenvatinib or sorafenib. But ideally, we want to go with the IV formulation of what I've listed before. Now, if patients don't tolerate that, or if you have a progression of your cancer, we have second-line chemotherapy options that I've listed here. And then we also have third-line chemotherapy available to us. We have a clinical trials group at the University of Calgary in our liver unit, and we're always recruiting patients for clinical trials. So that some patients that don't fit into these categories sometimes may be eligible for clinical trials. And so I hope that I've shown to you that there's a dedicated team of specialists that anytime a patient is discovered with liver cancer, that we try our utmost best to look at every possible type of therapy that we can think of, whether that's non-invasive, invasive, all the way to chemotherapy. And there's many ways that we can mix and match therapy for patients. And so all hope is not lost, and we try our best to work with the patient and ensure that the patient's goals are being met before we really decide to move on to palliative care. And palliative care has historically had a negative connotation with patients, but actually it is a form of therapy where we're trying to enhance the patient's quality of life, reduce caregiver burnout, and address many of the symptoms that patients with liver disease actually experience. So many of our patients, I talked about the big things that we always worry about earlier in my presentation, but these are other symptoms that patients with liver disease always experience that sometimes we forget to ask, including myself, and sometimes the patient doesn't mention it as well. And so this may include concentration difficulties, sleep difficulties. Fatigue is often a major concern of patients with liver disease in general, let alone liver cancer. A lot of patients have muscle cramps, sexual dysfunction, pain is big, and a lot of our patients have depression and anxiety, which leads to lower quality of life and higher burden among caregivers. And along with that, we know that our literature shows that about 50% of palliative care consultation is performed in the last 72 hours of death, and most of it is done in the inpatient setting. And so what we really try to focus on is, even when you do have liver cancer, we want to begin these conversations early and addressing them. We're always hoping for the best. We're always hoping to achieve a cure with the test. But we do have to be realistic and acknowledge that a lot of patients will not make it there, and that there are other symptoms that we can treat that are easily treatable, I would argue, that actually improve quality of life for the patient and ensure the patient is maximizing their time with their significant others and enjoying life. And so I did want to talk about our large program, which is one of the most unique in the world, I would say, that was developed by Dr. Swain over a decade ago. We have an automated liver cancer screening program that we've partnered with EFW Radiology across the city and a significant part of southern Alberta. We have screened over 10,000 patients that are eligible for screening that could be at risk for liver cancer. Traditionally, we know that only about 30 to 40% of patients that are eligible for liver screening actually do get screened. And this may be due to patient barriers, taking time off work, the cost of driving, traffic, bus, Oftentimes, appointments are not mailed correctly. There's miscommunication between administrative staff and the patient. And then physicians themselves sometimes aren't aware of what the screening guidelines are, and they may forget to order it themselves as well. And so typically there's patient barriers, provider barriers, and system barriers. And what this program, we've taken out a provider barrier as well as a system barrier, and we found that about 75% of our patients, so remember 30%, 40% was the status quo. We've increased it up to 75%, which is truly remarkable and never been seen across the world. And so what we're doing right now is we're conducting research and looking at this program and seeing if it's had a benefit like other screening benefits of colon cancer and breast cancer and how we've done over time. So truly remarkable feat. And so what I would conclude, and a little bit biased here, but the liver is the best organ in the world, and thank you for all coming. So, but you need to take care of it, so we've talked about that previously here. Liver cancer is preventable and curable if it's caught at the early stages. There's many, many therapies that are available through a network of physicians and nurses to help you live longer and quality of life if cure is not even achievable. And then the Calgary Liver Unit research is conducting large-scale epidemiological studies, which I've talked about. And if you're ever interested in participating, donating, seeing what our unit's all about, please shoot me an email. We'd be happy to give you a tour of our unit and everyone that we work with. And yes, and keep spreading the news about liver disease. Again, as I said, thank you, Carrie. These functions are very important because it's just not me or Mark or Simon that can do this alone. We need just thousands of people, and we got to keep speaking up and breaking down those doors. So thank you all.